Thank you everybody for joining us for tonight's webinar, Building a Dry Eye Center with the OCULUS Keratograph 5M. Tonight joining me is Dr. Eric Botts. Dr. Eric Botts is president of Energize, the Association of Corporate Affiliated Doctors. He's also the CEO of OBC Credentials and Billing Specialists. Also joining us is Dr. Chad Overman. Dr. Overman was an independent doctor of optometry for Walmart for more than a decade. He also served as their Director of Professional Relations for about 5 years. And now Dr. Overman is a consultant for Oculus, as well as several other companies that are focused on the management of dry eye disease. So thank you guys for joining us.
Thank you, Chris, for having me.
So I'll get started into the discussion here. Before getting into the different modalities for diagnosis, I wanted to just quickly touch on dry eye disease and kind of give us a definition of dry eye disease. The Dry Eye Workshop in 2007 defined dry eye disease as a multifactorial disease of the tears and ocular surface, and they said it involves dysfunction of one or more tear film components, increased osmolarity of the tear film, inflammation in the ocular surface, and it results in tear film instability, damage to the ocular surface, discomfort, and visual disturbance. So one of the things I really wanted to emphasize is that it is a multifactorial disease. Here's a dichotomy of dry eye, also given to us by the Dry Eye Workshop in 2007, and they said that dry eye can be aqueous deficient or evaporative. Dr. Michael Limp gave us a study published in Cornea in 2012 that showed that really only about 14% of dry eye patients are purely aqueous deficient, and that actually about 50% of those patients were purely evaporative dry eye. And then 36% had some combination of evaporative and aqueous deficient. So it's really important to be able to measure tear film quantity as well as tear film quality to get an idea of what kind of dry eye this patient has, whether it's evaporative, whether it's aqueous deficient, or whether it's both. So I'll get into the Keratograph 5M here, go over some of the features and benefits of it. One of the things that makes the Keratograph very versatile is that it has several different illumination systems to give us the optimum illumination depending on the type of measurement or image you're trying to get. Also, it has a built-in magnification changer to give us the optimum magnification depending on the type of measurement or image we're trying to get. So one of the most popular features of the Keratograph 5M is mybography. Here's an actual photo from a Keratograph 5M. As you can see here on the right, we have the raw image, and then we actually have an enhancement that we do in order to give you a better look at the meibomian glands. Dr. Botts is a Keratograph 5M user. Dr. Botts, could you speak a little bit about how you use the mybography and how it benefits your dry eye workup?
Sure. So just going back to what you spoke about just a moment ago, the percentage of patients who have evaporative and aqueous or just evaporative is 86%, meaning most of those patients have some kind of meibomian gland dysfunction. And what I love about the Keratograph, especially being able to pull this up in the exam room with the patient, is I can show it to them exactly what's going on. I can tell them that they have dry eye disease, and now I can explain to them why. With the mybography, I can actually show the patient where the meibomian gland dysfunction is at, because some of the scans that I pull up are just superb as far as the quality. You can, it's just so easy to see where the glands have died off or stopped functioning. And a lot of patients, they understand when they can see what's going on. And that's what I really like about the mybography, is it starts the conversation with the patient. They don't feel like you're lecturing to them. You're actually explaining to them exactly what's going on. I use this mybography on almost all my dry eye patients.
In general, one of the biggest things that we promote about it is patient education, being able to show the patient, look, these are normal meibomian glands, and these are your meibomian glands, and this is why your eyes are dry. So here's just a couple other things we see. Here's somebody with meibomian gland dysfunction. As you can see, there's several truncated glands. There's some missing glands there. Another thing that we see sometimes, and I don't know if you had any experience seeing similar conditions. This one is we see some dropout, but also we see very tortuous glands here. Now, the pictures that I have here, both the upper lid and lower lid are inverted. Dr. Botts, do you do both lids, or do you do just the lower lid?
I typically just do the inferior lid at this point in time, primarily because I think it becomes pretty time-consuming and can be a little more difficult for my tech to actually invert that upper lid and get a good scan. The lower lid typically shows some dropout, some damage, so it's easy to use the lower lid as your educational tool in this case. So no, I don't do the superior lid very often.
And I would agree with that. As far as feedback from other doctors as well, we hear that doing the lower lid, it gives enough information. It's great, still great for patient education, and then it's good from a workflow standpoint as well. And just to give you some more images, here's somebody with a high percentage of dropout, and again, several missing glands. And some of the glands that are left here in the inferior, as you can see, they're very dilated.
Chris, this is Chad. I'll touch on it a little bit later, but I've listened to a lot of doctors and their frustration with trying to express the lids and warming masks and the things that they're trying to do, and then if they just had the information that there weren't any glands there to begin with, that would change their treatment plan and protocol. So again, I'll touch on that a little bit later in the presentation, but I thought it was a good point to bring up of why meibomian gland, being able to view them is so important.
That's a very good point. Just in general, being able to look at the structure of the meibomian glands is going to be able to give the patient a good prognosis. Another feature that I'll point out is the fluo imaging. So this is not simulated fluorescein. This is actual fluo imaging. You can do still photos. You can also do video. Now here's just a still photo. As you can see, patient with some corneal staining. And this is really no different than looking at corneal staining through the slit lamp. If you don't have an anterior segment camera, then this gives you the benefit of having documentation, and then again, being able to communicate with the patient what's happening with their eyes. So also with the fluo imaging, we do have a grading system. This is a manual grading system. So where you have the patient's image, and then we have a grading scale below, and then you can actually slide that picture along and it'll give you a score. So that's another benefit, is being able to maybe more accurately grade the staining pattern. One of the other products, this is not from OCULUS, this is from Rapid Pathogen Screening, an Inflammadry, a great product, and it looks for MMP9 proteins. MMP9 is a non-specific marker for inflammation, and this is something that's very easy to do, and it can really give you a lot of information as far as whether inflammation is happening, whether it's visible or not. But Dr. Botts or Dr. Overman, is this something that you have experience with in your own practice?
Yeah, this is Dr. Botts. I use this test every day on dry eye patients. Typically what I do is I use the Keratograph oftentimes as part of my protocol in screening for patients that are potentially going to be dry eye patients. The reason I love the Keratograph is, unlike the RPS, the Inflammadry, and the TearLab, which we'll talk about in a moment, there's you don't have to pay to do the Keratograph. Once you own the instrument, you're not paying every time you use it. One of the drawbacks to the Inflammadry and the TearLab is that every time you use it, it costs you money for the test. And so what I typically do is I use my Keratograph first because I've got the instrument, I own it, and like I said, it doesn't cost every time I use it. Once I establish that there's suspicion of dry eye with the Keratograph, then I'll definitely do the Inflammadry. The inflammatory is a great test for me to determine whether or not I would start the patient on Restasis or punctal plugs. I mean, if you get a positive inflammatory, you're not going to put punctal plugs on the patient. You're typically going to do some kind of anti-inflammatory treatment, whether it's Restasis or steroid. If it comes back negative, then you still may do Restasis, but then I feel comfortable using a punctal plug if necessary.
That's an excellent point. Now, so you're saying for, I guess it kind of helps increase the bottom line, be able to determine whether or not you're going to be able to bill for this by screening first and then using the inflammatory.
Yes, yeah, I absolutely use the Keratograph as a screener. For example, all of my contact lens wearers get a Keratograph to determine whether or not there's any possibility of dry eye issues for my contact lens wearers. It's nice to know ahead of time whether or not I'm going to have issues with dry eyes on a contact lens wearer. And then if it comes back positive, well, then I'm going to go into a full dry eye workup, including inflammatory and other tests.
So I will mention one thing that we do have on the Keratograph. It's our R scan. This is going to give us a grade on the redness of the bulbar conjunctiva. So the inflammatory is great. Again, one of the limitations of the inflammatory is that anytime there's MMP9s in excess of 40 nanograms per milliliter, it's going to be a positive result. So if you have somebody with severe inflammation and you've managed this and they've gone down to a moderate inflammation, then you're still going to get a positive result with the inflammatory. One of the benefits of using the R scan is that this gives us a number to follow. Is the patient improving? Is there no improvement, and do we need to maybe change the approach? But again, that's one thing that is available. I just showed the video on it. It's a fairly easy test to do, and this one is an automatic assessment. So just to kind of give you an idea of what's happening in the background here, we're actually using sort of a red-free filter here in the software, and we're able to actually detect where the vessels are. And we look at the conj to vessel ratio, and then we convert that into an empirical grading scale from 0 to 4. As you can see here, this is somebody obviously with some red eyes, and they're very close to a grade 4 and grade 3.9. And then just to give you an example of what this grading scale looks like, here it is right here. So most adults being a grade 1, and then the grade increases with bulbar hyperemia. We did have a recent study that came out looking at the R scan. It was published in Vision Science in 2015, and basically said that its reproducibility was the highest compared to 3 other modalities that they looked at. And just to give you a little more insight on the study, the other modalities that they looked at were your typical grading scale, where the doctor looks at some pictures and chooses a grade, whereas this, again, we're using something a little more objective. So it's no surprise that it ended up being more reproducible compared to the other 4 modalities. So far, we've really talked about damage to the ocular surface, inflammation, structure of the meibomian glands. To talk a little more about function, so what does the tear film quantity look like? What does the tear film quality look like? I'll talk about the tear meniscus height. So some other options for looking at tear film quantity are the Schirmer's test, the phenol red thread test. As I mentioned, we use the tear meniscus height. The benefit of that is that it's non-invasive, definitely more comfortable for patients, and it's a lot faster. So with the tear meniscus height, this is an image that is taken, and then calipers are used to actually measure the tear meniscus. Just some studies showing the tear meniscus height. So compared to tear meniscus height on a slit lamp, it showed very strong correlation, had good precision. average reproducibility was plus or minus 0.02 millimeters, which is very good. And then another study published compared it to tear meniscus height on the Fourier domain OCT and showed that it had good correlation with the FD OCT and had good repeatability and reliability as well. So again, this is our method for assessing tear film quantity. For tear film quality, the Keratograph specifically has a couple other devices. We have the non-invasive breakup time, which I think Dr. Botts, you're a fan of, and then the lipid layer imaging as well to look at the actual meibum that's actually in the tear film.
I'm a huge fan of this test, Chris. This is the test that I do on every contact lens wearer, on any patient that meets my protocol for a potential dry eye patient. The non-invasive tear breakup time is the test that I do. What I love about it is that once again it gives you a great image to show the patient, but more important, it also helps me measure success with my treatment plan, because this is a test that I'll repeat maybe 3 or 4 times a year on a patient, and every time they come back and we repeat the test, we can go back and look at what did the last test look like. Did it get better? Did it get worse? If it's getting better, whatever treatment that I prescribe for the patient it's working, we can actually measure success. And to me, this test has really invigorated my dry eye clinic, because being able to measure success is how I can get my patients to buy into a treatment plan and actually perform the treatment that I ask them to do. It's improved compliance significantly.
And Eric, you and I have talked, but when you have that patient sitting in your chair and to have something to show them instead of just saying, "How do your eyes feel?" Right?
Yeah,
and,
yeah.
An awful lot.
Yeah, I've talked about that many times before, in that prior to getting the technology in my office, like the Keratograph, the Tear Lab, the Inflamadry, I would treat dry eye patients and I would have them come back in, a month, 3 months, 6 months, whatever, and to measure the treatment success at that point in time, sometimes it almost was embarrassing to me to have a conversation with them about, how do their eyes feel, or there was just nothing scientific about it. What I have found is when I start them on a treatment plan, and I usually have them back in 2 weeks, and I repeat the NICBUT, more times than not, I'm getting if they had a 2 to begin with, we're down to a 1, even possibly a 0. If we had a 1 to begin with, we're down to a 0. I mean, quite often I'm seeing an improvement with the treatment that I'm prescribing for them. If I don't get them down to a 0, it doesn't mean the treatment didn't work. It just means we got to do more. We got to be a little more aggressive. So it even kind of tells me how well it worked, and points me in the right direction on do we have to do more for this patient.
Just to fill everybody in a little more on what the non-invasive breakup time is, we're basically projecting Meyers onto the tear film, and then we're looking for distortion in those Meyers during a video, and that's going to tell us that the tear film broke up at that time. So it's a pretty easy test to do. You actually line it up just like a topographer, and then as you'll see, there's a message on the screen, tells you to have the patient blink twice. It starts a video, and then again we're looking for distortion in those rings, telling us that the tear film is actually broken up at that time. So it's really an easy test to do. It's easy for technicians. Really, a couple practice runs, and then they're ready to go usually. And what it gives us is a display that looks like this. It gives us a color map. This is not a topography map. What this is a map indicating the time and the location of the breakup. As you can see, we have a legend over here telling you how many seconds it took for the tear film to break up. And then we have a graph giving you the percentage of breakup as a function of time. To make it a little bit easier to understand, we do have a classification. We have a level 0, a level 1, or a level 2. Level 2 being a very short breakup time, indicating a very unstable tear film. A level 0 being a normal patient.
So Chris, when I'm showing this to a patient, this is typically when I start asking the patient if they ever notice what I call intermittent blurriness, or the vision's clear and then it's blurry and then it's clear again. And you'll be surprised when you start talking to patients about blurry vision, how many have that complaint, but you got to describe it to them for them to really say, oh, that's what I have. But what I tell them is that what this is really showing is how quickly their tears are evaporating, and any place you see a red or dark orange spot on this picture is where your tears are evaporating between blinks. And every time your tear evaporates between a blink, you're going to have a dry spot on the surface of your eye, and that dry spot is kind of like looking through a smeared windshield, and so it causes blurriness. And I'm amazed how many patients say, you know what, that's exactly what's going on. It's clear and then it's blurry, and then and it's opened my eyes to how many of my patients have dry eye issues, and how many of them have been coming to me for the last 20 years, and I just haven't picked up on it.
Eric, that brings up a great point for me. Can you share how many people going through your practice that comes up with a report that looks like this that you weren't previously diagnosing as having dry eye?
Gosh, I am probably going to say I'm doing, I'm going to say maybe 700-800 tests a year in the last year have come back with a 2 or above. I would say more come back with a 1 or 2 than come back with a 0. The more I do it, the more I see. So I would just tell you that they've been suffering in my practice for many, many years prior to getting the technology to really detect it.
Because they're not coming in complaining, right?
They're not coming in complaining at all. It's not until I start asking questions about it that they perceive that there is a problem there. They just live with it. Some of them they just assume that was normal. And I know that because when patients come back 2 weeks or a month later after I start them on treatment, they're like, oh my gosh, this is so much better. I'm seeing better. My eyes feel better. They're the ones that are telling me what kind of success we're having, and I wouldn't have picked up on it before.
Yeah, and think of how many of those wore contacts in the past and just dropped out because they thought they couldn't wear contacts anymore.
Absolutely.
So I love the fact that you're doing it on your contact lens patients.
Well, I just feel like I've been blaming the contact lenses for years and years on why the patient is not comfortable with their contacts. Now I've taken a different approach. Now, if a patient is having any discomfort with their contacts, the first thing I do is do a dry eye workup and find out exactly where we stand. And I'm surprised at how many even 25 to 30-year-olds that I have wearing contact lenses that will come back with a nick butt that looks just like the one you have on the screen right now. I would think that most of my patients in their 20s, would be all green with a great nick butt score. It's not the case though.
Yeah.
Well, going back to the contact lenses, I wonder how many of those contact lens patients that you just never talk to again. They have discomfort and they drop out and basically decide that contact lenses aren't for them, or that they need to go somewhere else, that kind of thing.
Too many.
Well, yes, a lot. And the chair time that you waste trying the next brand and the next brand without really any improvement. And I don't know about you, but when they come back to my office for for contact lens follow-ups, it's not really, I'm not charging them for it. It's part of the initial fit. But when they come back for dry eye checkups, absolutely, I'm going to bill their insurance for it. So not only does it treat the patient, but it's a whole lot more economically better for my practice to be charging the patient for actually helping them instead of just fitting them in another lens for free.
I'm hearing happier patients and happier doctors here.
Absolutely.
Oh, that's great. So we have technology now. That's what I'm so excited about, is we have technology that will allow us, and I think you said it earlier, to scientifically be able to talk to our patients about disease state that we as optometrists just have not really been able to do that in depth before, and this allows us to do it. So that's where I get very excited about what the Keratograph has to offer. And then I'll go in some of the other ones we'll touch on again later too. But the technology gets me very excited.
So something that Dr. Botts alluded to a little bit before, and it's just a feature I'll point out real quick. So you can actually compare those non-invasive breakup times side by side. So again, if you have a patient that comes in, you can do a baseline, and you can gauge the efficacy of your treatment on follow-up visits using this very well, as you can see. And feedback that I've gotten from other doctors, they really like this. It really helps them, especially when patients' symptoms. A lot of doctors are some of our key opinion leaders are saying that patient symptoms are really not a very good metric to go off of for dry eye. So having something like this that's more objective that we can use to follow, I think is an important part of the dry eye workup.
Chris, I'd agree with that. I read a study on Sjogren's disease last year. The study was actually done a couple years ago, but it showed that I want to say 40% of patients with Sjogren's dry eye disease didn't have complaints. So I can only imagine that the number for patients that don't have Sjogren's disease but have dry eye issues, the number of patients that aren't complaining is even higher.
I would definitely agree with that. So just some clinical trials data. It does show good repeatability, good sensitivity and specificity. Another one that I'll quickly discuss here is the lipid layer. This is qualitative with the Keratograph. It allows us to zoom in on the lipid layer of the tears, and the idea here is the broader the spectrum of colors that we can see, the thicker the lipid layer is. So again, going back to the meibography allows us to look at the structure of the meibomian glands, how much is left. We can look and see dilation of glands, tortuous glands, that kind of thing, but it doesn't really tell you anything about how the glands are actually functioning. And that's where the non-invasive breakup time comes in and the lipid layer test comes in. And just to show you a quick video of what it looks like with somebody with a good thick lipid layer, as you can see, it looks like oil on water. Again, this is a good way just to observe the function. Another thing, again, not an Oculus product, but something that's definitely a good part of a dry eye center is a tear lab for measuring tear osmolarity. Now, Dr. Overman, I know that you're a consultant for a tear lab. Now, Dr. Botts, I believe you also utilize the tear lab in your own practice.
I do. I've used the tear lab for well over a year now. This is really where I got to start with my dry eye clinic, was with the tear lab, and it is a really, really good test to utilize in an optometric office. It's quick, it's easy to do, and it gives you really good information. And it's the one thing I'll emphasize though is that I don't think you can put all emphasis on any one test. You can't have a dry eye clinic with just a tear lab or just inflammatory or just a keratograph. You really need all the pieces of the puzzle to be able to be a good clinician and take care of your dry eye patients. Because occasionally I'll get a normal tear lab and a 2 nick butt on the same patient. And so you know they got a tear film issue. If I was just relying on the tear lab, it would have maybe sent me down the wrong path if the tear lab was normal that day. So having multiple tests to run on your dry eye patients, I think is really important. The tear lab being one of them.
I completely agree, Eric. I think we need to focus on the overall dry eye clinic. Keratograph, I think, is a cornerstone. I think tear lab is, and I will put inflammatory in there in that as well. It gives somewhat what we talked about before. It gives you numbers. So you've got science now. If you, Eric, if you get a 320 on a tear lab, the first day, and then you start a treatment, and when they come back, they're now 290 or 300. You know you're moving in the right direction, right? You've got something.
Absolutely.
But you can show that patient instead of them saying, well, my eyes feel better today or not.
Right.
So I think I like how you put it. It's not just one test, it's putting them all together. And I'll be honest, I stole shamelessly from you, Eric, on some of your billing and coding. I'll give you full credit, but it's in the deck later on. And it kind of tells everybody, what they can use and how they can do it. And I think tear lab with inflammatory, and then the keratograph as your screener, and that's why I call it the cornerstone, to be able to find these people so that you know who you can and should do the tear lab and inflammatory on is extremely important.
Thank you guys for that. So moving on to the last little thing I'll talk about with the Keratograph is the Yinvis dry eye report. Basically, this is a report that's going to consolidate all of the dry eye information into a single display. It's useful for assessing severity and tracking progression of dry eye, and improves the workflow for dry eye exams for full dry eye workups. And the printout is really a great tool for patient education. Kind of puts all of these metrics into one place, and you can show the patient. It's very intuitive, as you'll see here. So the idea here is that when doing a full dry eye workup, the technician can go through the tests one by one. The tests are put in a good order so that the one test does not influence the next test. And, it gives us a automatic grading on it. As you can see, it's very intuitive. Traffic light system, green being normal, red being very conspicuous, and as you can see, it automatically populates after the measurements are done on most of the tests. And this is what a filled-in dry eye report would look like to the doctor or the technician. One of the things I'll mention on here, you have all of the Keratograph tests that you can do, and that goes into this report. But we also talked about osmolarity. That's something that can be added to the report just for the sake of having it on the report, and so it's on the printout, the patient can see it. Here you can actually put your practice logo on here. Again, the intuitive grading scales that everybody's going to be able to understand. The doctor can put in their recommendations. It's very nice because you can have preset recommendations. If you have a common therapy that you utilize, you don't have to type it in every time, but you can also manually type in any recommendations that you have. We mentioned inflammatory. There is nothing for inflammatory on here. One of the reasons being that inflammatory is a binary test. It's either positive or negative. So it would either be all the way in the green or all the way in the red. However, what I've seen a lot of doctor is doing is just having a text block saying either inflammatory positive or inflammatory negative, and then that does go into that text box. And then it does describe all the tests, whether they're OCULUS tests or not. The definition would go on here, and it's going to be in terms that the patient is going to be able to understand. Dr. Botts, are you utilizing this? Does this fit into your protocol? And if so, how do you use it?
Well, what's nice about it is you've got something that you can hand the patient at the end of the exam that they can take home, gives them a little more education on what's going on. And what I find is patients, when they come back for follow-up, they actually can remember what some of their scores and some of their tests were from previous exams, and they're actually now buying into this fact that the treatment is working. And you know, there's no better way to get a patient to be compliant with treatment than to have them buy in that the treatment is working and that they need to utilize the treatment that you gave them. So the report, I think, is just excellent for motivating the patient to perform whatever treatment you've given them.
Excellent, and that's really, I think, what OCULUS is going for here on this. And so I'm glad to hear that that is effective. So just some things I wanted to put in there. You know, for somebody that's interested in starting a dry eye practice, you know, who are your patients? Obviously, you're going to have your patients that come in where dry eye is the chief complaint. We talked about having contact lens patients, do a dry eye workup for them, and manage the dry eye before dispensing contact lenses or at the same time to try and stop the dropout, and then also, you know, improve the bottom line a little bit, really. I mean, I think everybody cares about patient care, but you know, it also needs to be good for the practice as well. So referrals, there's a lot of doctors out there that see dry eye patients but don't manage dry eye, so it's a way of getting good referrals. And then Dr. Botts, you mentioned screening quite a bit and how many people are asymptomatic that you're finding, and so just, you know, everybody is potentially a dry eye patient if you look for it. So
I agree. I probably, in the past year, I probably have 300 to 400 patients right now that I'm actively following with dry eye, and I'm just going to tell you, folks, that's 300 to 400 patients that came through my door as established patients. I haven't been marketing for dry eye at this point in time. Those are just patients that I was seeing regardless. They were coming to me for their eye care, and I detected the dry eye utilizing the technology that I have in my office. And that includes contact lens patients. That includes patients of all age. And honestly, patients over 60 are almost always going to have some kind of dry eye issue going on, whether they're complaining or not. I have a few patients that can pass every dry eye test I perform from the geriatric crowd, but vast majority of them have some dry eye issues going on. So you know, if you're seeing Medicare patients, for example, you're seeing dry eye patients.
Good point, Eric.
The only other thing I'd say about, oh, go ahead, Chad.
Oh no, go ahead, Eric.
I was going to say the other thing I'm going to say about technology in my practice. You know, I've been, anybody who knows me knows I've been a believer in having the best technology in my practice, and the reason that is for me it works. It works because I've always felt like practicing in a corporate setting means that I've got to do better than the rest, and the best way that I can impress on my patients that I am going to provide them the most comprehensive care is by utilizing the best technology. And I think sometimes in a corporate practice, the technology makes me stand out from the other doctors in my communities that I practice in, and it helps me build my practice. And I've got, you know, big successful practices, and I got to say that having the technology has been a big part of that, whether it be dry eye technology, which is what we're talking about tonight, but you know, OCT, retinal camera, things like that. But this is all part of you know, providing that full scope optometry.
I agree, Eric. I've always loved how you embrace technology, and you've done a great job of helping teach me over the years the different technologies out there, so I greatly appreciate it. I was going to mention, Chris, when you talked about, you know, needs to be good for the practice, I always start with that when I'm talking to doctors about building a dry eye clinic, that, look, baseline, I'm not even going to talk to, you know, I know you want to take care of your patient. So that being said, let me show you how you can really help your bottom line. And I've been briefly saying it a few times, but I know it's coming up here soon, and I will quit teasing people, and we'll go over that. But, yeah.
So why don't I let you, Dr. Botts, and Dr. Overman talk a little bit about the available treatment modalities out there, and what you use as far as your protocol. What are your go-tos?
Yeah, Eric, let me start, and then I'll
Okay,
kick it
sure.
over to you. Okay. You know, probably everybody on this call, I would say 100%, you know, understand the treatments that are out there. You know, I've listed these. I'm not sure if all of our colleagues are really using the supplements, the omega supplements, as much as they should. It's a part that I know everybody understands, artificial tears, but I really would like to see a push into that nutraceutical side, because I think that helps tremendously. And then, you know, the warming masks and LipiFlow, I wanted to talk about that because, again, if you're doing those but you haven't seen the meibomian glands, you know, what if you have 50% dropout of meibomian glands and you don't understand why the masks and the LipiFlow aren't working? Because they don't have the meibomian glands there available for it. So I just wanted to touch on a couple of those. We'll go into, you know, at the billing and coding part here in just a moment. But Dr. Botts, I was wondering, you know, of these and any that, you know, I haven't listed here, what are your go-tos, and, you know, kind of those 300 to 400. I mean, I think you've got a great sample already built up, you know, to give us some clinical pearls on what your protocol is.
Sure. So, you know, typically when I diagnose somebody as having dry eye, I've done the keratograph, and typically if the keratograph is pointing towards dry eye, then I'm going to do a tear lab the same day. What I typically start patients out on is artificial tears and some kind of omega-3 supplement. And I'll tell you what, folks, what I have found with the omega-3 supplements is that within 2 weeks, I typically can get anywhere from a 10 to 20 point drop with the tear lab. I can get a 1 to 2 grade drop with the keratograph, the NICBUT, because that's the test that I typically do with the keratograph is the NICBUT, the non-invasive tear breakup time. I can get them to go from a 2 to a 1 or a 1 to a 0 in two weeks time. So that's where I start. And what I do with fish oil, folks, is I go over to the pharmacy. I mean, it's 50 steps out the door. I go over, I pick up the omega-3 that I think is best for the patient. I bring it back to them. I hand it to them. I tell them how to use it. And typically I recommend approximately 1,000 milligrams of omega-3 for about every 100 pounds of body weight. And no, I don't weigh the patient, but I do kind of size them up, get a feel for you know, where I think they're at. Sometimes I'll even tell them this is what I recommend, and they'll tell me how much fish oil they'll need because they know how much they weigh. The only thing that I don't want to do is you don't want to go over 2,000 milligrams of omega-3 supplement per day. So I'm anywhere from usually 900 to 1,800 or 2,000 milligrams of omega-3 a day for patients. As far as artificial tears go, I do tell the patient to use them, especially when they're doing up close work, because I think that's when their eyes are typically going to dry out the most. That's when their blink rate is decreasing, so their tears are evaporating between blinks. So I tell them to use artificial tears, and I emphasize to them that these drops are strictly going to get your eye wet. There's no medicine in them. They're not treating anything. They're just to get your eyes wet. What I have found is when they come back in 2 weeks, they're very compliant with the omega-3 because most patients are already taking some other kind of medication. So I just tell them, you know, typically make it part of your routine. Take these pills when you're taking other medicine. However, I do recommend that patients take the omega-3 with a meal. Take it when they're eating something else is the best time to use omega-3. So what I found when they come back in 2 weeks is they're taking the omega-3s and they're using the artificial tears about half as often as I recommended to them, or not at all. Compliance with artificial tears is just so-so. Compliance with omega-3 is usually pretty good. So at that 2-week visit, if they come back and I'm getting a huge improvement, and you know they've got a 1 or 0 on the nick butt, because I'm going to repeat that test at 2 weeks, and I'm going to charge for it too as well. If that comes back and we've got an improvement, we may follow that for maybe 3 months to see how they do. If I don't get an improvement with that, then I typically am going to do the inflammatory test at the 2-week visit. If that comes back positive, then I'm going to start them on Restasis. I've become a big fan of Restasis in the last year. I have found that it's not as expensive for the patients as what I thought it was, that Restasis has some different programs that they can use to really decrease the cost. If they have meibomian gland dysfunction, if they have, if I push on their lids and I'm getting a lot of not clear but white or opaquish looking sebum coming out of their glands, I'm probably going to give them a Bruder mask. I buy them by the case now, and I just hand them to the patient. Unfortunately, Walmart doesn't sell them this time of year. They were selling them during the winter months, so I would send them. I would go over there, pick one up, and sell it to them, and Walmart would sell it to them. But they don't have it on the shelf now, so since I can't sell them, I just give them to the patient and give them a Bruder mask if I think that they have any kind of meibomian gland dysfunction going on. If the inflammatory comes back negative, I don't hesitate to put punctal plugs on them. If the inflammatory is a dark red positive, I might even start them on Restasis, and in addition to that, start them on a steroid as well. The blood serum drops, I really don't have any experience with that at this point in time. I don't have any experience with the LipiFlow. Anybody who knows me knows that if it doesn't have a CPT code to go with it, I struggle with any instrument, with any test that I can't charge for. So I don't do a lot with the LipiFlow at this time. So that's my treatment in a nutshell.
Appreciate that, Eric. I think, again, just with the number of patients that you've had, the audience can benefit greatly from kind of just picking your brain and hearing your flow. The blood serum and light therapy, those aren't done very often. I just put them on there as, they are therapies that are out there. They're a little more costly. Light therapy also does not have a CPT code to be able to bill. So, it's costly for the patient. there's still isn't as good as some others that we can do. But I think we can all learn from you, Eric, how you go about that. And I like the fact of what you said about Restasis, because I too have found out with their My Rewards program, it's not nearly as expensive as I once thought. I did put 90-day RX here because there's an awful lot of patients that are getting a 30-day RX, and as we know, Restasis doesn't always work within 30 days, so patients think they didn't get any benefit. Plus, the copay on the 90-day, they can actually pay no more than they do for the 30 days. So I think that makes us look better as practitioners too, if we help the patients as much of that up front as possible, writing you a 90-day prescription, not a 30-day. It will take a while. You have to stay on this. You got to keep doing it. So I think that's important.
Yeah. The other thing I'll say about Restasis, especially since this is an Allergan presentation, is I tell the patient there's plenty in a vial to use for 2 doses. So when you give them a 90-day script, it's actually 180 days is what it'll last a patient, and that really cuts the cost down. So that's where I've really found Restasis is not necessarily as expensive as what I once thought for a lot of my patients.
Absolutely, and I think those that are listening to the webinar, you can go and look up on Allergan's website a lot about their rewards program and learn for yourself too that what Eric's talking about, and you'll find out that it's not as costly, but it really helps an awful lot of patients that they do need it. Thanks.
One of the things One of the things I'll note on there real quick is just that you mentioned Restasis a lot of times doesn't work in 30 days. Again, what we're hearing from a lot of the power users, the Keratograph owners that have had it for years and years, is that patient symptoms don't always improve right away. A lot of times they're seeing improvement in the ocular surface that precedes the actual symptom improvement. So to be able to have diagnostic equipment, going back to that and saying that, look, this is actually working, just stay the course, and then being able to get compliance out of that patient, I think is important.
Yeah, and the last thing I would add also is keep in mind with dry eye patients, folks, is that it's a chronic disease. You're not going to treat these patients for 2 weeks or a month or 3 months and cure their problem and say, I'll see you in a year. These patients I'm going to follow up with in 3 to 6 month time frames, depending on how severe their dry eye is. And folks, that's probably going to be for either their lifetime or mine. For a lot of these patients, it's not going to go away. We may never clear up to where they get a normal NICBUT or a normal cheer lab or a normal inflammatory. We may never get that. We're going to treat these patients for a long time. And so when you do start your treatment with them, you need to set some expectations for the patient that this isn't going to be a quick fix. This is going to be, this is going to be a long race, not a sprint. And you got to be in it for the long duration. And just, tell them what's going to happen from the get-go, so they know what to expect. And you know what? This is how you build a loyal patient base, is taking care of their medical problems.
Very well put.
So, go ahead. Sorry.
No, you did exactly what I was just asking. I appreciate that.
So, yeah, I know that it's a question everybody has when we start talking about dry eye practice. What is reimbursement? How is it going to benefit the practice? So, Dr. Overman, I'll let you take it away with that.
Yeah, and again, I give Eric lots of credit because I've probably from multiple times I've talked to Eric and listened to him, I've kind of picked these out of. So this is where a dry eye clinic will really grow your bottom line. And we've talked about the Keratograph. You've got the photos is the code. It's 1926 for both eyes, but again, if you're doing it 2 to 4 times a year, as Eric has been alluding to, he's going to bring these people back much more often. And then you've got the tear lab, you've got the Inflamadry. Now you're not, Eric kind of touched on it, you're not making a lot of money off of tear lab and Inflamadry. Because you don't own that like the Keratograph, but you can still, there's a code for it. And then the punctal plugs when they're necessary, you've got that. And then those office visits, you're going to charge, and Eric alluded to this, it's not like a contact lens follow-up. This is a dry eye workup or follow-up, and you're going to charge them, and you're going to do the appropriate test. So when you get to the bottom of this, I was doing one line at a time, and I'm thinking, yeah, okay. But then when I added it all up, and each dry eye patient, and if Eric has 300 to 400 that he didn't have to do any outside work to get them into the practice, they're already there. But incrementally, these people add $496 to $781 per patient to your bottom line. So if you diagnose 200 patients that are already in your practice, that's $99,000 to $156,000, and it's net. This is not the gross. This is your net after paying for everything. That was, I know, Eric, that was the first thing when you showed me, what you were doing. I'm like, is that gross or is that net? And it really hit me that this is something that we've already said it's great for the patient, but it's incredible for your practice. And then think of how many of these patients are the ones that are going out saying, Dr. Botts is taking care of me better than anyone else has been able to do. I have had kind of, sore, tired, itchy eyes that now feel much better, and they're going to stick, and they're going to remain in your practice, and then they're going to refer others to your practice. So this slide, take a photo of this slide, and it'll tell you a whole lot of what you need to know, but it doesn't capture the contact lens patients that have dropped out or went elsewhere that you're now retaining because you've taken care of them. And it can't really grab, how much of the referrals are happening, but it's a tremendous practice builder. And I think you'll find that, Eric, you seem invigorated and excited about, seeing a lot of taking care of these patients that are already in your practice. So I think it's great from that. It's awesome to go to work each day and be able to help people.
This is, the dry eye clinic has gotten me more excited about practicing than I've been in a long time. It really has invigorated me to provide better care for my patients, and the results are why that is. I mean, the patients who come back for their follow-up visits and they're doing better is just it's exciting to see that something that I did that was actually so simple to do is making such an impact. One of the things that I have found is, a lot of these patients you're going to diagnose when they come in for their yearly exam. You're going to diagnose them as having dry eye issues, and you can either set a treatment plan at that time, or you might say, you know what, I want you to come back tomorrow or in a week, and we're going to do a dry eye workup. Whichever you decide to do, that's up to you. It really is dependent on your patient flow. But I would encourage you to do this. since most of them are coming in for their yearly exam, when they come back for their follow-up visit after you've started treatment, be sure and do acuities, because it amazes me how many of my patients will say, Dr. Butts, I see so much better, because honestly, I didn't think visual acuity was that big of a symptom of dry eye. I always thought of it as being red eyes or dry, uncomfortable. But what I have found is that blurriness, poor vision, is just as big, if not the most important symptom that you're going to treat for your patients, because when they come back for follow-up care and you have them reading the chart and they're actually seeing better than what they were seeing before you did the exam, that's extremely rewarding. That makes you feel good. The other thing I want to add to this slide is that 92285, no matter what test you do, and there's a lot of tests you can do on the keratograph, and no, you're not going to do them all as part of your initial diagnosis for dry eye, because it's just not going to allow a good patient flow. But you pick one or two of those tests and you perform them, that's what you're billing the 92285 for. Even if you just do one test on the keratograph, it's a 92285. It doesn't matter how many tests you do, as long as you do one. So I do want to make sure that you understand that. And to attest to this slide, I will say the first year of my dry eye clinic has netted, taking all the expense out for paying for the keratograph, for paying for the inflammatory, for paying for the tear lab. It added $96,000 to my bottom line. That wasn't gross. That was net. That was profit. And I'll just tell you, folks, when you have 3 kids in college, like I do, that is important. And so it's been exciting in more ways than one for me. Most importantly, patient treatment has been increased, but a dry eye clinic pays for itself probably better than any piece of technology I've brought into my practice.
Thank you. I mean, that's great clinical pearls, especially on the visual acuities as well. I like that. So I learn something from you every time I talk to you, Eric. Appreciate it.
Yeah, I'm definitely glad that you pointed that out. I think it's often overlooked that the tear film is part of the optical system. Just to summarize, and hopefully you guys will agree with me, there is a need for dry eye centers. Managing dry eye can improve your bottom line, and specifically with the keratograph, I know we mentioned other instruments, but with the keratograph we can provide objective information important for the success of a dry eye practice. We can help distinguish what kind of dry eye you have, whether it's aqueous deficient or evaporative. We can look at the severity of the disease. We can look at the damage to the ocular surface. Also, it's good for gauging the efficacy of your treatment again. And then, as I mentioned, the patient education, and Dr. Botts mentioned quite a few times, being able to show the patient their condition, and it really hits home for them, I think.
Absolutely. Chris, I appreciate you putting this together, and I just want to throw out anyone that watches or is on this webinar now, watches it in the future, you certainly can reach out to me. I will answer any and all questions that I possibly can for you about a dry eye clinic. And again, I thank Dr. Botts for educating me so much over the last year, where the majority of my education has come from. So thank you.
Very welcome. I appreciate the opportunity to participate tonight.
Yeah, thank you very much. It's an honor to have both you, Dr. Botts, and you, Dr. Overman. We really appreciate you being here.
Thank you, Oculus. Appreciate it.
Great instrument. I appreciate it.
Dr. Botts and Dr. Overman have both been kind enough to share their email address. So if you have any questions, you're welcome to contact them. Both doctors are very knowledgeable about dry eye clinics. Both have experience practicing optometry in a corporate setting. Oculus hosts a clinical webcast approximately once a month. We record all of these webcasts. If you're interested in viewing any of our past lectures, you can go to our website, www.oculususa.com, go to the webcast section, and view any of those prior webcasts. If you're interested in attending any future lectures, you can also sign up for the newsletter there and be notified of any future lectures that are coming up. If you have any questions or comments regarding this webinar, or if you have any questions regarding Oculus products, you can contact us at sales@oculususa.com or call us on the number listed on the screen. I thank everybody for attending, and have a great night.